All right. Well, good. I guess it's still good morning, everyone. And obviously, the first thing I think we want to do is just take a second and have a quick moment of silence for the people who were harmed in the bridge incident and the adverse effect to the city. So we'll do that really fast. All right. I will say this just on a quick personal comment. You think about those poor road workers who were killed and, they were public servants who were doing work for the government. And then you think about those police officers who managed to stop the traffic and save hundreds of lives. We don't thank government workers enough for what they do. And most of them do it for less money than what they could make in the private sector. So I do think we should think about that. And also we should thank all the state workers who are on this call today helping make the healthcare system work. So having said that, to start the EQIP Primary Care subgroup meeting, and again, these meetings are recorded, so if anybody misses it or anybody wants to follow up, I did get a couple questions about if the meetings were going to be the same every time and a couple other questions about logistics. Essentially, what these meetings that we've set up are for is to develop the EQIP Primary Care Program from the subgroup. So I will say this, that some of the comment letters we got talked about adding some primary care like bundles. I don't think we're going to talk about that in this group a whole lot because we've been doing that in the EQIP meetings, and we are definitely, it looks like, adding a UTI bundle, and we are working very hard on a behavioral health bundle that could be for primary care possibly. So that is probably going to move forward, I would say, with a relatively high level of certainty. We really want to focus on this other idea that we've been talking about, which is the critical area access primary care program. And we're really excited about it. And I'm going to turn the meeting over to Krista, who is going to talk about where we are and get a lot of feedback today. So Krista, it is all yours. Go for it.
Awesome. Thank you so much, Jean. And thanks everyone for your interest and continuing to make the time to attend these meetings and provide feedback. The presentation today is really intended to share how the policy has evolved, but would just note that nothing is absolutely set in stone currently. So we continue to welcome any and all feedback as we move this work forward and would really appreciate continued feedback. I would ask that you hold questions until the end because I'm covering a lot and your question may be answered later in the presentation. So, okay, so I'm going to provide just a very quick high level background on EQIP Primary Care, just for folks who may not have heard at the last meeting. So CMS approved a one-time reversal of the MPA Savings Component implemented in January 1, 2023 for calendar year 2023. And the state set aside the majority of this amount to fund targeted investments to improve the reach and effectiveness of primary care in Maryland. As you can see here in these bullets, there was $19 million that was set aside for this EQIP Primary Care Program intended to expand access and to address primary care availability in underserved areas of the state. And funding will be made available to organizations to subsidize this expansion. And we expect that over the long term, this will reduce the total cost of care for patients who currently lack access to adequate primary care. And the anticipated start date is January 1, 2025. And assuming that folks know what MDPCP is, but this program really intends to supplement MDPCP in two ways. It will focus on the expansion of primary care access, where MDPCP focuses on strengthening and transforming existing practices and does this very well. So we are really about the expansion of primary care access. And this funding will be focused, again, a little bit of a differentiation in currently underserved areas. MDPCP encourages safety net providers to enter, but does not set requirements on participation based on underserved areas of the state. So an important distinction. The state plans to implement this program in certain geographic areas that are underserved, as I've stated, and specific metrics will be utilized to determine what underserved is. But we anticipate that this will be a mix of urban and rural areas in the state. Again, a small number of organizations will be chosen to receive the infrastructure, per-beny, and shared savings payments for up to 5 years. And we will set criteria and share the scoring metrics in advance of the application, including a few of the bullets below, and I'm going to talk about this in more detail later in the presentation. And I just want to make a note here. HSCRC strongly encourages multi-payer alignment with this program. It really allows practices to serve more patients under an aligned approach. So in turn, affording them the ability to transform care across their entire patient panel. So we may not be there on day one, but we want to work with other payers to really align primary care. Okay, so let's get into the meat here. Since our last meeting, we've taken feedback from the RFI as well as continued stakeholder feedback to solidify this framework. And I'm going to start with the scoring criteria. So the scoring criteria, there are several items here. I'm going to talk about them in a little bit more detail. The first item, which is 25 points in the application, will be about the organization's background and qualifications for delivering high quality primary care. And what we really mean here is, or what we want to see is that the applicant is demonstrating experience in delivering high quality primary care, either in a value-based care arrangement or PCMH. They should be demonstrating recent successful experience with opening a new practice or location and or significantly expanding operations, or be partnered or sponsored by an organization with such experience. The next item here available for 25 points is the model of care. And what we're looking for here is that they're meeting sort of minimum standards, and we'll talk about the model of care a little bit later, but meeting those standards and speaking to how their model will better meet the needs of the target populations rather than establishing a primary care practice that has a one-size-fits-all vanilla approach to care. They should really be demonstrating intentional focus on serving these disparate populations. The next item is worth 20 points, the organization's knowledge, presence, and experience in the geographic focus area. And for this item, we're looking for applicants to demonstrate understanding of the needs of the population or have experience working in this geographic focus area. If there is no experience working in this area, they should demonstrate the creation of some kind of formal partnerships within the community. For example, maybe executed MOUs within a certain time frame after initial funding is released, something along those lines that really shows that they are and defines a partnership on how it will achieve the goals of the program. The next item is the work plan, staffing model, and recruitment strategy. So for this piece, which is 15 points, we're looking for the applicant to demonstrate that they have a recruiting or recruitment strategy in place that aligns with their financial request. We will be providing a financial sort of application and template where the organization will indicate how much money they need, how many MPIs they plan on hiring, things like that. And this the recruitment strategy should align with that financial request. And there should really be a demonstrated commitment to introducing new physicians to Maryland rather than moving them from one geographic area to another or just shuffling people around. We'll be looking at that. And the applicant should be demonstrating the appropriate mix of practitioners for a multidisciplinary care team, again, that aligns with their financial model. So we'll be looking for things like a timeline, the staffing model and recruitment strategy, and then we'll be looking for milestones in the work plan as well. So that more detail to come on that, but that will be an important component of the scoring criteria. The next item is care coordination and practice support activities, which is 15 points. And we see this as sort of, the role that the CTO plays in the Maryland Primary Care Program. We're not specifically calling that, but the practice should demonstrate that they have the capacity to perform functions, including hiring and managing an interdisciplinary care management team that can provide an array of care coordination services to the beneficiaries in the practice. So those types of services that the organization demonstrate that they can provide include pharmacist services, nutrition services, behavioral specialist services, linkages to social services, et cetera, et cetera. And that in that application, that team should demonstrate data management and analytic capabilities as well. And again, the organization that's applying may choose to hire an entity that can perform these functions as well, if they're not in-house within staff. And the next couple of items, woman minority status, we're offering 5 bonus points for a yes on that. And then we'll talk about the critical priority areas, but we're offering 5 bonus points for practices that are establishing in higher needs areas. And again, we'll talk a little bit more about that later on the presentation. Okay, so the next bucket here is the funding streams. This has not changed drastically since the last meeting. I think I'm going to walk through some of the nuance here. As I mentioned before, there will be a financial template in the application where the applicant will indicate how much of an infrastructure payment they're looking to receive. And so, keep that in mind as I'm talking through this. But the infrastructure payment will be available for the first 2 years of the program. And those annual payments will be made to practices in the last quarter prior to each program year. And again, that's for the first 2 years of the program, starting in 2025. The next is, again, the beneficiary payment. This is available years 3 through 5. These payment amounts will be set by the HSCRC, and these per Medicare Benny amounts will be calculated on a per month basis, but paid in the first month of each quarter. And they will be, these payments are going to be based on the latest available Benny counts with a sort of true up to final Benny counts in future quarters, because those will be projections of sorts. And those per Benny amounts will be set separately for duals and non-duals. And then we're also including an add-on payment that's going to be made available for beneficiaries who meet the criteria for what we're calling lacking primary care. And I'll talk a little bit about that later in the presentation. And then we have the shared savings component, which is still being fleshed out, and we don't have detail on that today, but that'll be available years 4 and 5. Those payment amounts, again, will be set by the HSCRC, and they will be upside only, similar to the EQIP payment methodology that's currently in place. Okay, the next item I'm going to touch on is the focus area selection, which I know folks are very interested in. And we've been working on how to sort of slice and dice the data to really get at where are these underserved areas of the state and how do we measure that? And we've kind of landed on this proposed methodology and really look forward to folks' input. But so by identifying these zip codes where primary care capacity we believe should be increased, we really see this as conceptualized as areas with high potential need for primary care and low supply of primary care. And the first way that we're sort of looking at this is using the HPSA, the Health Professional Shortage Area measure. We see this as a measure of primary care supply. And this is comprised of provider to population ratio, travel time to nearest source of care, and proportion of the population in poverty. I'm sure folks are very familiar with HPSA. There's advantages and disadvantages. So we can talk about that in more detail, but the next measures that we're looking at are PQI and ADI. Folks may be familiar with these as well. And PQI really captures information about ambulatory sensitive conditions, and ADI captures information about social determinants of health. And we think that these are measures of primary care need. So each capturing different aspects of that need. So using a combination of HPSA for supply and ADI and PQI for need, we have analyzed the data and believe that setting certain cut points for each of those to target around 20% of the state's population may be the fairest way to identify these target areas. Higher need may be those with low primary care supply and high primary care need. And then high need may be those with low supply and moderate need. So saying all that, we're going to take a look at a map so we can see kind of where all the data landed and what it looks like. So I'm sorry I did not include a key. The red areas are, what I'm calling today higher need, and the pink is high need. And the blue dots are MDPCP practices. So this is very exciting. I think, as you can see, the areas are spread across the state, and their areas that we have heard from stakeholders are critical areas of need. So we're happy to see the data kind of back to those assertions. We have Western Maryland, Baltimore City, a little bit of Harford and Cecil County, Prince George's County, and several areas on the Eastern Shore, including Dorchester and Somerset counties. And then in the enlargement of Baltimore City, you can see a little bit of the butterfly, not surprisingly, and a fair amount of higher need and access areas in the red and then in the pink, with the MDPCP practices dispersed pretty kind of evenly-ish. So while this is still a bit of a work in progress, we do hope to finalize what these target geographic areas will be very soon. And we will be releasing that in advance of the applications go live so that interested organizations can determine if they're eligible before applying to the program. Okay, the next item is the model of care. This has not changed drastically either since our last meeting. We really formulated this based on all of your feedback from the RFI, as well as all of the primary care model literature and evaluation. So this model of care has been brought together by, through a combination of ways. And really the goal for this is that in the application, applicants will be asked how they plan to address each of these pieces of the framework specific to their geographic area. So how will a practice build care management, chronic condition, self-management, support services, how they're going to do that is what we'll be looking for in the application, and really using that kind of population health lens to meet the needs of the people in their specific community and geography is what we'll be looking for. And again, I'm not going to walk through each of these points, hasn't changed a lot since last time. And folks in the application should feel free to expand on this as well. It doesn't have to be 3 bullets, 2 bullets. Like, we are looking for thoughtfulness, innovation, all of those things. But these are kind of like the bare, I hate to say bare minimum, but these are the minimum requirements that we're looking for. Okay, so attribution. This is the strategy, and it's tentative. We're hoping to finalize it soon, but I think we're still working through some of the kinks. But what we have at the moment is that we will attribute bennies to a primary care provider that's participating in the program when the Benny has their first claim for an annual wellness visit or welcome to Medicare visit during the performance year. And we wanted to make this as the least complex as possible. And we think that this is a pretty fair way to do the attribution. The next piece is how we're defining lacking primary care, and that lacking primary care will be for that add-on payment that I discussed a few slides ago. And what we're considering lacking primary care is patients that are coming in with 0 or 1 primary care visit in the year preceding attribution to a primary care provider participating in the program. And there are no restrictions based on prior eligibility or anything like that as well. And a note here that organizations must establish a new TIN for MPIs operating at that practice for a lot of reasons, very specifically for attribution, of course. Okay. The next item is reporting. And again, this is a bit of a work in progress, but I think where we've landed is requiring a sort of annual progress report, for lack of a better way to say it, but where practices will attest to and report on certain requirements. So we're looking for things like, do they have a minimum number of patients? Is the practice open? Has your practice hired at least 1 physician and staff? Has your practice put care coordination and practice support functions in place? Does the practice plan to stay open? And future funding, may be withheld depending on the practice's responses. Obviously, if the practice is saying they don't plan to stay open, then don't think we can justify providing funding. So I think we want to make this reporting as least administratively burdensome as possible. Of course, always have that in mind. I think we'll also be interested in looking at whether the practice is meeting the requirements of the model of care. So are they doing the things that they said they were going to do for their patients? So we're still trying to figure out what that looks like, but I would anticipate something along the lines of like the fidelity to the model of care that they proposed will be part of that as well. And that will be done a few months before the end of the performance year, going into the next performance year. And lastly, the quality reporting. There will be no quality reporting required in the first year of EQIP Primary Care. We plan to work with practices, stakeholders, with the subgroup to develop that quality framework, but we anticipate that it'll be very similar to MDPCP. And of note, the MDPCP reporting suite that is currently used for that program will be made available for this. And that's obviously through CRISP. I think folks are familiar with that reporting suite. And next steps, and then we can take some questions. We have the next meeting on April 17th from 11 to 12. We are working on creating a document to send to CMS that will outline our thinking on the program. We'll get feedback from them. So that's coming up in April. The application will open mid-May through the end of June. And this is not correct. It says followed by, I'm sorry, I didn't go to the next slide. It's not, we will have an opportunity for Q&A during the application window. We can talk with organizations, practices to answer questions and help them through the application process. We'll review the applications in July. Applicants are notified at the end of July, and then enrollment in the EQIP portal will begin, will be through the end of August. Okay, and then any questions should go to the total cost of care mailbox. And very exciting, we have a website with all of this information, all the meetings, all the documents. CRISP has, as a great partner, as always, has put this together for us. So that link is here. So with that, I will, I guess we'll open up to questions. I don't know. I know I have my counterpart, William Henderson, on the call if you want to add anything, or Jean, or we can open up to questions.
Okay, so I have one in the chat, but I also see Dr. Basinski took his microphone off and Dr. Haft has his hand up. So I'm going to give Basinski first because he was ahead of Howard, I think. Go ahead, Dr. Basinski.
Hey, thanks a lot. Can you hear me okay?
Mm-hmm.
Great. About the multi-payer alignment, you know, I mean, when I see this program, it seems like, you know, Medicaid beneficiaries are really a great target for this. You know, what's the hope? What's the reality of this? Is there a lot of barriers with MCOs participating in an alternate payment model? Or could there be something we tag on to our Medicaid visits, like there's a new G code showing primary care, and I know Medicare is reimbursing that, so maybe you could use that code and attribute some funding to it for this program. But I'm just curious specifically about that.
Yeah, so I can touch on that, and Chad Perman's on the phone on the call as well. I would, you know, he should weigh in. I think one of the things we don't want to do is get too far out ahead of MDPCP. And I know the MDPCP is working through their Medicaid alignment, specifically under the AHEAD model. So I think we'll probably be following their strategy. And I know that they're working on that, and there's funding set aside to do that. I think that does include working with the MCOs and additional funding, Medicaid funding. So I would say most likely we will follow suit to what MDPCP is doing, but also, you know, can think about other ways, and certainly Ken would welcome if you want to kind of send those ideas or have a talk separately about that. I'd be happy to entertain that with William and myself. But I don't know if, I don't want to speak on behalf of MDPCP, but I think that's kind of our thinking at this moment. There's a lot going on with the head and that alignment. So.
Oh, great. Awesome. Well, thank you very much. I'll be in touch.
Yeah, absolutely. Thank you so much.
All right, go ahead, Dr. Haft.
Yeah, thank you, Jean, and Jean, Krista, everyone who's involved in this. Just congratulations and kudos in synthesizing and condensing a lot of really important thought to put this new and really exciting program on the map. I have one comment and one suggestion. The comment is related to the scoring, and it goes back to equity. So I appreciate that there is a small portion of the scoring that goes for minority and women-owned entities, but I think the equity issue is greater in Maryland than just minority and women-owned, and that we have a growing kind of disparity for physician-owned and operated enterprises, where hospitals and private equity, venture capital, other corporations have really been taking over a lot of the ground. And I think here in Maryland and, and nationally, there's at least some level of concern, if not some really serious considerations about that transformation in terms of quality, in terms of costs and things as that process continues. So I think equity always speaks to allowing those who have least capabilities, giving them the resources to be more competitive on the playing field or have a fair share. So I would think that either adding a percentage for physician-owned enterprises in the scoring, or increasing the amount of minority and women-owned enterprises is a way of continuing to infuse equity into the scoring of this program, which is all about equity and its basis would be good. So right now there's a piece in that, but it's embarrassingly small piece that speaks to equity. So that's my comment on that. And my suggestion, and I hope it's a useful suggestion, is that in terms of the annual reporting, I know that Mark Luckner and the Community Health Resources Commission has an annual report that they require for their people that they've granted funds to. It's a very simple report. I've used that many times in grants that I've received from there, and it might be at least a framework for reporting back, since it's already been used for many years. And
Yeah, that would be very
well worn.
helpful. Mm-hmm.
So that's all I have to say. Thank you.
So
again,
actually,
congratulations.
thank you, Dr. Haff, for the kind comments. And look, the fact that I can't understate how much work that Christina and Will and the people at HSCRC has done to get this far along. So really, it says a lot about the great staff and hard work they're doing. I wanted to just say that I really agree with your first comment, particularly, and I would also suggest we might want to think about looking at the equity and that equity piece, as well as adding the things you just talked about. Maybe we should also talk about the equity related to the patients they're going to be serving as well. Maybe that could be another part of the scoring. So maybe we can take a deeper dive into that piece of it and maybe try to suss it out a little more and figure it out and either add something else or figure it out. So I thought those were really helpful comments, Dr. Haff. Thank you.
Yeah, and I just one note, Howard, Dr. Haff, we actually had physician-owned versus hospital-owned and getting points for physician-owned. And then we started to realize, like, what if a community mental health center comes in, and it started to get very complicated. But I think your point is well taken, and I think we'll take that back and reassess, because I understand your point. It's noted. Thank you.
Thank you very much.
So go ahead, Kimberly. I'll let you go next, and then we have a question in the chat.
Thanks, Jean. Thanks, Krista. I have more of a logistical question. There was a slide that mentioned it would be necessary to set up a new billing tin for this program. And our practices are all part of a medical group, so they're all in the same ACO, and we currently have a billing tin set up for that ACO. With this program, would we be able to continue using that tin, or would it be necessary to set up an additional one?
I'm going to say that I think we would probably, in order to determine if it's new access, but I think we would probably still ask for the creation of a new tin, but that we might have to talk through that a little bit. We don't want to create unnecessary administrative requirements, but I will take that back, and we'll get an answer to that.
All right. Well, we'll look at that closely. I think the trick is we need to balance the ease of having, people participate and be able to participate versus we can't have a situation where some large national ACO comes in, uses their tin, and then just takes existing people who are already here, and we're not really creating anything new, and we're just giving more money. I think that's the concern that we're
Yeah.
hearing from CMMI and others, that it needs to really be, we're really trying to produce new primary care practices with this. I'm going to go ahead and read the question from Cindy regarding attribution from the chat. Will patients only be attributed based on annual wellness visit and WTC visits? What if they have ongoing care with the primary care physician, but not an AWV or a WTC?
Thank you. Great question. At this moment, we are just looking for the AWV and the Welcome to Medicare. I think we've looked at a couple. We've looked at the data, and I think we think this is an appropriate way to establish new primary care, and we see this as, you know, a simplified way to do that. And I don't know if there's other folks on the line that want to weigh in on that, but at this point in time, this is what we're looking to do for the attribution.
And just quickly in the chat, Dr. Motormass pointed out, I agree with giving scoring points to physician-owned practices. 91% of new grads are employed, and now 70% of physicians are employed in the state. David Lur says, it'd be extremely burdensome to have a 10. We need to get contracts with payers for that 10. And I will say too, just to his point, that we are hearing now that some payers are not allowing people to join their networks, which was not really the case for a while. It ebbs and flows. So you really are putting the new practice at a little bit of a disadvantage, because they're going to have a 6-month lag while they try to get into some of the networks. And then I think Chad asked again about the AWV attribution question, which you just answered. So Will Daniels with Care First.
Hi, thanks, Gene, and thanks, Krista. I think this is very well thought out. I like the attribution methodology. I also do think the focus on the TIN is important, and while there is some administrative burden, to getting a TIN and signing up with payers, I think it really does indicate that the practice is new, right, and not simply previously existing providers. I would encourage you to also focus on MPIs, right? And so maybe look at TIN MPI combinations or an increase in MPI count, something like that. Just be a little worried, an existing practice that changes its TIN but doesn't add additional MPIs,
Yes.
wouldn't be adding additional capacity in that area.
Absolutely. And we actually just talked about this yesterday, how we're going to monitor that it is new capacity, and they're adding beneficiaries, and yeah, absolutely. Thanks, Will.
All right,
Great.
Dr.
Wonderful.
Bazinski.
Hey, thanks again. 2 quick questions. One, the HPSA score, is that primary care specific, or is that all providers, the HPSA score that you're looking at?
I have to look back at the document. I believe it's all.
Because if you're using it as a marker of primary care staffing, you could have a hospital with multiple specialty physicians, and that'll drive down the.
I believe it is
yeah,
primary care.
Is there a primary care HPSA?
Krista,
Yes.
this is Ian from App. Yes, that is primary care.
Yes. Okay. Thank you so much, Ian.
Appreciate it. And then I just want to go back to the TIN issue. I think creating a new TIN is like starting a new business. And all your contracts are then negated. You have to recontract, and contracts that you've worked on and negotiated over the years would be lost as a private practice, at least. I don't know if there's more finesse in large organizations where they can do this without any headache, but yeah, that would be very problematic for a small practice to do that. It would be very disruptive, and it would really and I'm not sure it really capture new business. It would show business that shifted to a new TIN, but maybe not necessarily new patients. So I would push back on that if anybody's listening. So
no, appreciate that. I guess I would kind of say back to you, like, how would you, or do you have thoughts for how then you would kind of like figure out if this is new access? Like how will you then sort of define that new access?
Well, it seems like one of the drives is bringing in new providers. So, I mean, a new NPI number, that makes a lot of sense. I'm not sure what else you would do in terms of new access. I mean, increasing access, you can see increased visit numbers. You can see, number of patients seen, you know, new location with a, if your new locations are what you want. I know locations have their own identification, so maybe it's a new location number or something like that, without having to go with a whole new practice TIN. So
Okay, that's helpful. Yeah, thank you.
Okay, Raquel.
thanks for being listening.
Sure.
Hi, everybody. Happy to see everybody on this call. Exciting initiative. Raquel Sampson, University of Maryland. I've got some questions that people wanted me to ask. So, model of care. I appreciate all of the work done here. We know advanced primary care is really where MDPCP sits. Are you looking for different models of care aligned with advanced primary care? What are the thoughts there? We don't want to be too far afield from what we've already developed and built under MDPCP, but I also want to hear your thoughts there.
So I guess my initial response to that is kind of what we've laid out here. We're looking for these three major kind of tenets of the model of care. So I don't think they're that far off from MDPCP. So we would just be looking for you to, you know, kind of align with this. If you go above and beyond this, great. If your model of care goes, you know, is differentiated, but we're not looking for you to create a whole new primary care structure. We just want to make sure that what we have heard from you all and from the literature is that your program is sort of aligning with that to the extent possible. And if you feel like you can't align, we'd love to hear why and what you're doing to sort of meet the needs of the population. And so does that
Got it. And do you guys, well, can you indulge me for two other quick questions, or do you want me to re-queue?
No, you are indulged. Go ahead.
I can re-queue. So the other thing is we spent a good amount of time in the RFI, and we really appreciate how you've been able to synthesize this. I understand how incredibly challenging this is. And I think there's a balance between being too burdensome, but giving enough instruction that you're actually crafting something that needs to be different than what we have. With that being said, I was a little bit underwhelmed by where in the scoring with collaboration with existing partners or new partners. I think if we're going to really tackle the equity thing, nobody's done it well. If we're going to go into West Baltimore and you're going to get 20 applications, I think that's really upsetting to me. I think there needs to be more of that in a way that I understand it. Not do we have a presence and do we have experience is not getting it for me. It's what are the meaningful collaborations and partnerships that you're going to bring to the table to address a population that thus far has not been able to access care. So I'll just put a pin in that. Do what you want with that. You don't have to respond. Second one. But
why don't we respond to that? Because I do think you're making a good point. I think so let's talk about it for a second. And I do think maybe in the process, do you think it would be helpful, Raquel, if maybe we had like a bifurcated process where we saw what came in, and then if we had 20 in West Baltimore, maybe we try to encourage them to work together to do one application, so all the partners are working together and we get something better? Would that be helpful in kind of solving the problem, or do we have some kind of solutions? Because I think you're making a good point.
Can I just say one thing? I don't mean to be interruptive. I do think, and this isn't laid out. I think it was an Excel document that was awkwardly placed on my screen, but that is a part of the requirements, in the detailed requirements, is a collaboration with community partners. And maybe that's not clear in here. Your point is absolutely well taken. I think we can expand on that and make sure that is required and points are, part of that requirement. So I don't know if there's more to that I'm not understanding, but I 100% agree with you on that. So I think I would welcome some language or like some thoughts if you have some time. I
think it's collaboration with other primary care providers as well as community partners, because I think there's some, University of Maryland might do very well partnering with a community primary care practice and expanding or evolving or what have you. But then I think there's the need for the community groups that are doing whatever, from door knocking to screening to whatever, that may not already be established.
Yes, and then we would absolutely want to give credit for that if it's happening, and if it's not, they don't get. So I totally agree.
Okay, good. Then it is there. You just need to flesh it out further. And then the last thing I just want to say is seemed to be something that we felt pretty strongly about, and just from past lives, really having a business plan for sustainability. And I understand that we have things talking here on the point system about work plans, staffing model, recruitment strategy. I really don't think you're talking about adding 1 or 2 NPIs or 1 or 2 FTEs. I think we're talking about a long-term plan that needs to be grounded in a sustainable model. Having worked with different payers where groups have come, primary care groups, independent or large systems have come to try and collaborate, and I was on the MCO side at the time. I don't think a simple nod to this for 15 points is significant enough. I think we have to be thoughtful that if we're going to invest, and I hate to harken back to the HEZs, I swear to goodness, if anybody wants to send me a nastygram, I totally will accept it. But there were successful and less successful expansion and folks coming in to Maryland that were not here previously that have done pretty good jobs in some areas. I also want to support the idea that it shouldn't be a one and done. I think it has to be an evolution over time, which a real thoughtful and market analysis, business plan, and I know you don't want to exclude some groups, but this has to be done in a robust way with these dollars. I would hate to see this money fettered away. Other monies have in past projects and programs. And I just want to say, I respect all the work you do. I respect all the things you've done for this, and I know how hard it is. So thank you.
All right. And maybe actually that's another argument for maybe bifurcating or breaking up the application process to make sure that people do have the wherewithal to complete what they're promising. So that's another good point, Raquel.
And Dean, I would just say on that back end, having people collaborate as opposed to starting out that conversation and forcing people to talk about that rather than slamming them together after the fact might be a consideration.
Well, if you have suggestions on how to do it right, please reach out to us because that's
okay.
great. Yeah, it'd be helpful. I see, Will, I'm going to let you go again, but let me go through the chat ones real quick. Stuart asked, are you still considering, would you consider a patient mix of commercial lives and CMS lives? This would help balance the financials. I don't think that's going to be a problem. The one point I would make is, and I know you were involved with some of these stand-ups on the ERISA plans, you're only going to get paid on the Medicare lives through the EQIP program. So if you did something on the commercial side, that'd be great. If you did that so you could make economies of scale work, I don't think anybody would object. But it would, again, you're not going to get paid on the non-Medicare lives. Then Cindy said, could you use a TIN plus NPI model for attribution? And then Robert suggested TIN/group NPI, new combination. And Raquel said NPIs. Howard Half said, on the plus side, new contracts with payers in underserved areas usually are higher rates, and the time frame for contracting should include the funding model. And maybe Will can tell us that Care First will just let anybody who wants come in, and that would solve our problem. And then now Natalia said, I echo that and wonder how some of these community partnerships or elements of the model care can contribute to the HE scoring. So having said all that, I will let Will comment again.
Great, thanks, Gene. So first, I think from a Care First perspective, we definitely like to see additional providers in these areas. And so, if you're entering, please reach out to Care First, either myself or our regular networks people. Just on the TIN point, I think one of the previous commenters said that to start a new TIN, you need a new business. And Krista, you can correct me if I'm wrong here, but I think the intention is to create new businesses in these areas. And I think from my perspective, you get a lot more bang for your buck if you're opening a new business and a new practice in one of these areas. You have to plan for sustainability. And if you're a large system or a large group that's adding 1 or 2 MPIs, my guess is the dollars are going to be, sucked away the same way that CTO dollars are sucked away to a central organization. And you're not going to get as much access. You're not going to get as much bang for your buck as if you're seeing real independent new practices starting in these areas. So I really think that TIN, requiring a new TIN is the right idea to get new practices and new capacity. And so I encourage you to stick with it. I do think, you need to, make sure you're not just seeing people rebranding under a new tin. But I think the new tin is a really critical feature of this program to get genuinely new capacity.
Yep. Thank you, Will. Appreciate that.
Go ahead,
Dave.
Mr. Lear, Dave.
So, to that same point, I think if the goal is to have this go solely to independent practices, however you define that, like practices owned by some group of people with less than a certain amount of revenue, perhaps, then that should just be stated explicitly. Because I could tell you, certainly
That's right.
we're the largest provider of free medical care for our community, which is something that certainly a small independent group certainly can't do. And setting up, my experience with some of the larger groups is that almost invariably they bill under one NPI with delegated credentialing and all sorts of other efficiencies that are helpful. If the goal is to simply add a location, then can't we just say that the regulation is to participate, you have to add a location and attest that you're doing that, otherwise you're committing fraud? Or if the goal is to add a provider, a net new provider who's not just transferring within the system, then certainly we could write a definition of what a net new provider is. And again, ask folks to attest rather than creating seemingly arbitrary paperwork to make it sort of an automatic that we can avoid writing a regulation that describes what we're trying to accomplish.
So Dave, I think those are good points, and we don't want to exclude anybody. So that's not what the goal is. At least that's my position. I would say, I think Krista, you would say the same thing, wouldn't you?
I agree.
So I think what we want to do though is we would just want to make sure, and I would say that I think my impression is from CMMI and from CMS that they want to make sure that the money is actually going to produce new practices or new access, right? So, and I do think there's some concern that at times in the past money has gone in to places and then the result wasn't there. So I think that's the goal. So maybe you give a higher priority to someone who has a new 10, but you can also hit the goal another way. And we're gonna go back and we'll do some work and come back at the next meeting and talk more about this. So I think there's gotta be a way we can solve this.
I think we could do a small subgroup on the tin issue if folks are interested. Maybe we can try to plan on that, but a couple meetings to hash that out and get folks' thoughts would be helpful. I know from myself and the other people on the team.
All right. Any other? Oh, go ahead, Raquel.
I just wanted to echo the comment Dave made. I don't know you, Dave, but can I call you Dave? And this point about and I've been here at UMS for literally 2 years. So I have a lot of feelings about the hospitals and their ability to reach and be the robust safety net for a lot of these areas that I think is critical and aligned with all of the work we're doing under the model, right? So I feel like those linkages have to be there. But I really appreciated Dave's comment about what are we creating and be explicit about that and who's able to hold it. So who's able to sustain over time the ability to deliver some subsidized care, some partnerships on how we've done that well or not done that well, and make that a little more explicit, because I do have reservations about one model or the other and how we want to craft this. And I do think to be open to everyone is important. And I also think it has to be really thought through on the business side. And that's the part I feel like is a little bit weak on this, and that we're going to do it later. We're going to pick you, but we're going to talk about it later. I don't think that's the work that needs to go into this.
I'm not sure that we said we would talk about it later. I think a business plan on sustainability is absolutely reasonable. And I think we'll take that into consideration as part of the scoring and requirements. So I just want to make that point. And I think we're really trying to strike a very delicate balance here. I think understood there's lots of perspectives, hospital independent, and I think we're really, and there's a lot of not-for-profits out there that can do some really great work. So I think what we really are interested in seeing what people present to us and really how they're focusing on that community. And I think that is the goal here. I mean, not regardless of ownership, I know there's a lot of challenges with, that, but I want to stay, focused on who can provide the care, who can demonstrate sustainability, and who is positioned in that geographic area to really meet the needs of the community. So we are balancing all that and hear all the perspectives and understand and welcome, the feedback. And we'll try to take it all into consideration as we build this. So.
And we also recognize that different
Thanks.
areas are going to have different answers, right? So Dave, I believe you're still with Meritus, right? Or that's where you are. And Meritus does a really good job working with the private docs in their community. They have a good relationship with them. When you go out to the Washington County Medical Society meetings, it's a complete mix of employed and private. Really, everybody's kind of working together. It's going to be a very different thing. And I think, you might want one answer there that you wouldn't want in Baltimore City, possibly, or in Prince George's. So we're going to have to figure out how to be dynamic and do it. But I don't think we're excluding anybody, but I also think, we all bring our own biases. So we want to be careful that we give everybody a shot to apply and we give everybody a chance to be successful. And sometimes administrative practices that don't have the high overhead of or small private practices that don't have the overhead of a hospital administration can provide a lot of free care. I know a lot of physicians in small private practices do see patients for free or see patients that they don't maybe have insurance contracts with or other things like that. So they do that as well. So we can't discount that. But I also recognize that hospital practices give a lot of free care. So anybody who can help solve the problem, we should focus on solving the problem and work with anybody who's willing to do it. So that's the goal here. Okay. Dr. Modermast.
Good morning, everyone. It is still morning. We have 8 minutes left. So I just want to say, great program. This is really exciting. My question is, so we are trying to serve a Medicare population that is basically disadvantaged, correct? So if we're asking people to open new practices, have we looked in those zip codes that we're calling out to see what the population, the amount of patients are that are Medicare of that age? I'm just thinking if I, as a practitioner, physician, wanted to go open a practice, it would be difficult for me to open a practice in an area and say, but I'm only taking this small group of people. And to make that financially viable for me is going to be problematic potentially without knowing how much of a need there is in that area. I'm sure there are some areas that have more need than others, but other things to think about. I'm thinking as we're doing this, if we're giving people money to open practices, we want them to take care of this little segment of the population, or it could be a larger, I don't know how many people live in these areas that are Medicare age, but do we want to call out something about the amount of, if you're helping someone open a practice, I don't know how many dollars that is going to be, but then what percentage of your practice do we expect you to be caring for these individuals? So you're building a practice that is really only about this type of group. Are you allowed to layer other type of practice patients in this as well? Is that part of your practice going to be supplemented with finances? So those are the things, just thinking about, if I want to go open a practice, what I would be thinking about and what my concerns would be.
No, great points. And we've done a lot of analyses. I don't know if Ian, if we've looked at the Medicare population in these areas yet, but I would just say we're not limiting. I mean, when a practice opens in an area, I don't think we would want them to limit it to the Medicare population. That's not a stipulation. I would think we would encourage them to open it to all payers. Just as Jean stated, I think this funding is really only for the Medicare population. Now, as you know, in primary care models, when you're getting this additional funding, that funding, can be spread across the panel if it's enough. So I think there's, overflow from the funding, but obviously we would really need other payers to participate to really make those payments robust and enhance that transformation across the practice. But it's definitely not. I don't think we want to limit it to only that Medicare population in a practice.
Well, on the flip side, I would say too, if I was the one giving the money, would I have an expectation that a certain amount of the work in this practice would be given to these certain type of patients that I'm paying you for? So you could all of a sudden say, well, I'm going to take the money, but I only have 1% of my patient population. And I know that you're doing attribution and you're getting money, but it seems like you're going to have to give a little bit of a heavier financial lift at the beginning if you're asking people to open up practices because they're starting from ground zero.
Yeah. I think the infrastructure, dollars help with that. But I totally, completely hear you and understand your point.
All right.
So if,
Sarah.
if you're going to give a lot of money, then maybe you want 20% of the population to be reflective of the practice as well. So it can go both ways.
Yeah.
I'm sorry, Will, did you want to say something? Go ahead, Will.
Yeah, this is William Henders from the HSCRC. I was just going to add a couple of thoughts on that. Yeah, one, I think the balance between the infrastructure payment and the per beneficiary payment is sort of supposed to do what you're describing there, in that the infrastructure payment you can use to support the practice, right? The per beneficiary payment you're only going to get from Medicare beneficiaries served. So that's sort of our way. And one thing I was going to add, although our slide says the infrastructure payment is only available in year 1 and year 2, we are actually going to allow people to request an additional infrastructure payment in years 3 through 5. Just 1 and 2, it's the only payment. Then in years 3 through 5, we're going to allow people to request, and that will be part of the ultimate evaluation. So I wanted to point that out because I think our slide only mentions year 1 and 2. But I think we are definitely, we do believe people should be building, complete practices that serve all payers. And it's just, as we said, we can only fund directly Medicare, and the infrastructure payment allows it to sort of provide a more broad subsidy. And the goal is to get practices into these areas and serve all the population. And ultimately, we do hope to align it with things like an a Medicaid MDPCP program, but we want to get started, and we can only directly fund the Medicare right now. And we also, one of the points you make, we are planning a higher payment on the duals, which is sort of one way to emphasize that Medicaid component.
Yep. Thanks, William.
All right, and Sarah, I think you might be near the end of our comments. Oh, you're muted.
Thank you. Sorry. I wanted to say, and you mentioned it in one of the slides, but the Johns Hopkins, Morgan State, Coppin State, University of Maryland schools of nursing have gathered together to develop a door-to-door geographic empanelment approach. And our thought is that primary care, real advanced primary care, will reach people who don't come into new practices and are homebound or homeless or hard to reach. And our thought is that we may need fewer new practices set up if we've got this new infrastructure that's going kind of zone by zone throughout the city and the state. And so that's another way of being able to address everyone without setting up a lot of new actual practices.
All right, and I guess Dr. Haft, you're going to get the honor of our last comment. Go ahead, or maybe I'll let Krista say something. Go ahead.
Thank you so much. But I just wanted to say that this is not a trivial program, and I've had an opportunity in talking to other states who are in the business of advancing primary care and investing in primary care to kind of just showcase in a very preliminary way this work that's happening in Maryland. And you really are the envy of every other state that's involved in supporting their population health. It's just, I just can't tell you how remarkable and how wonderful it is to be in Maryland and to have the leadership of HSCRC and Jean and Will and Care First and all those who are really making a difference in ways that just don't happen anywhere else. So no matter whatever else, we'll always have fair arguments about the right way or the wrong way to do this and split the hairs, but wherever it lands, this is just really an incredible advancement in terms of advanced primary care and health equity. So thank you very much.
Thank you.
Thanks. So this was a great meeting today, and I loved all the comments. It'll make it a better program. So Krista, do you have any closing comments?
No, just thank you. I don't know if we can get a transcript of the chat because you said a lot really fast and I'm not monitoring it. So I want to make sure folks comments are captured and we address them. So I don't know if there's a way to get that, but
all right, let me see if I can figure that out.
Okay. But yes, thank you to everyone. Continue to reach out to me directly, William, Jean, with any feedback. If you want to set up time to talk, I'm 100% happy to have those conversations, and really are just looking for you all to help guide this program. So thank you to everyone. And thank you, Dr. Haft, for your kind comments as well. And just lots of thanks. So with that, I guess we can go ahead and end, and we'll see you in April.
See you, everybody.